Thank you very much. Well, happy St. Patrick's Day, everybody. I see a lot of green out there. So in honor of St. Patrick's Day, and you can probably figure out with a name like Lisa Carey where I come from, I'm going to tell you a story. So an Englishman, an Irishman, and a Scotsman go into a bar, and they all order beers. The barman serves up the beers. They all arrive. Just as they're about to take their drinks, 3 flies come in, land in the beers. The Englishman looks disgusted, takes his beer, shoves it back to the barman. Scotsman looks disgusted, fishes the fly out of the beer, throws it on the ground, drinks the beer. The Irishman, equally disgusted, fishes the fly out of the beer, looks at it and says, "Spit it out, you bugger, spit it out." So everything we tell you, consider where it comes from, and consider that as we go along, we all have our own unique perspectives on the same thing. So I'm going to focus on breast cancer. You know, you're going to hear Howard, who's coming at this from a global perspective of how we give medicines and how we get smarter about giving medicines. I'm just a breast cancer doctor, so I have a limited armamentarium of drugs that I use, and I want to get smarter about using them. So the man who is the president of my national society once stood up at a meeting in front of 10,000 oncologists, and he said, you know, you guys think you're really smart, but just remember, one dumb tumor is still smarter than 10 smart oncologists. Sort of a sobering piece of information, and he was trying to get at sort of a self-congratulatory pose that people can have when we do have advances in therapy, but it is important to remember that in truth, 1 in 5 of my patients, even though breast cancer is considered a paradigm of successful intervention, successful screening, etc., 1 in 5 of my patients still die of the disease. The key to getting better at this is the research that we do, right? The only way that we have ever made an advance in anything we do for breast cancer or any other cancer is through research, which is something, it's, you know, sometimes patients come in and say, oh, I don't want to be a guinea pig. I say everything we do, lumpectomy instead of much more aggressive deforming surgeries, the role of radiation therapy, every drug we have, every screen tool we have, the only way we knew whether it helped or not was through research. So that's what you're hearing a lot about. Well, now, breast cancer research started a very long time ago. The very first therapy that was ever done for breast cancer has actually been published. It's you know, more than 100 years ago, was with ovarian ablation. They're taking out the ovaries in a young woman, premenopausal woman with metastatic breast cancer. And in truth, the breast cancer got better for a while. Now, of course, they actually had a theory about why that happened. They sort of made it up because they didn't have a lot of science to support them. And it turns out they were totally wrong, but what they did was right. And in truth, much of what we've done in the past is sort of, you know, the better, it's sometimes better to be lucky than good theory, because sometimes we do things we don't really know why it is, but they work for a while, and then we have to go back and figure out why. This is where we are today. Deaths from breast cancer, and I'm just going to focus on that one tumor, are dropping. They've actually dropped almost 40% in the last 20 years. And of course, you have the, you know, it's less filling, it's more, you know, tasty, these sorts of arguments, but in truth, it's half from better screening and about half from better therapy. Now, 40% sounds pretty good, but it's not good enough. We have to get better. So what I do, this is a picture of what I spend most of my time doing in the clinic. This is a typical story. So tomorrow, when I go to clinic, it wouldn't surprise me at all if I saw a 55-year-old woman who's otherwise a healthy woman, and she's had surgery for a breast mass, and it's a garden variety breast cancer. It's a medium-sized tumor. The surgeon's done a great job. He's taken it out. He also takes out conventional, this is standard therapy, the lymph nodes in the armpit, which are sort of attached to the breast and part of standard therapy. He removes those, and several of them, not all of them, but several of them have cancer in them. She doesn't have cancer anyplace else. So this, of course, gets to the medical therapy. I always tell patients that there's 2 problems with breast cancer. One is the problem of the cancer in the breast or in those lymph nodes, and the surgeon and the radiation oncologist are in charge of taking care of that. My job, and Dr. Irvin's job, is giving them medical therapy that'll keep it in the past and keep it from coming back 1 to 5 years later. So what is it that I tell patients to do? So the relapse risk of a woman with multiple involved lymph nodes in the era before we had any medical therapy to treat it, back in the day when my grandmother had breast cancer, was 80%. So 80% of those women were going to relapse, and most of those would die of their disease. With anti-hormone therapy, for those patients, the majority who have hormone receptor positive breast cancer, we can cut that risk by half nowadays. If you add chemotherapy to that, you can drop it another 10%. Nowadays, for 20% of the tumors, we have that HER2, which was one of the genes that Howard was showing you. We have HER2-targeted therapies that drop it yet another 10%. So we can take a woman who had a 80% risk of relapse and bring it down to being 3/4 chance of cure. Sounds pretty great. So that's the optimist view. Now let me show you what a pessimist might say about what I've told the patient and what I have to offer her. So 60% of the time, I overtreated her by a lot, meaning I used my most toxic drugs, chemotherapy, and these HER2-targeted drugs. While they're not chemotherapy, they take a year of your time, and they're IV, and they've got their own issues. And these are patients who would have been fine with nothing, right, 20% of the people, or just with an anti-estrogen pill. So that's 60% of the patients. 10%, the chemotherapy that I gave made all the difference in the world, right? Those are the ones that my counsel was spot on. I did exactly the right thing. And in that 30%, the cancer comes back even though the woman went through all of the things that we had to offer. So in her, we undertreated her. But we don't know exactly how we undertreated her, and we don't know how to make that difference up. So the problem is, of course, that we're not that sophisticated about figuring out what cancers are bad and what cancers are good. And in truth, cancers, a lot of what we use to gauge the aggressiveness of a cancer are things like how big is it and whether it involved those lymph nodes and things like that. And a lot of it is how it looks under the microscope. We're very reliant on our pathologists to help us. Of course, cancers can look like the one on the left, which to us is a low-grade cancer. It's considered a more indolent, less aggressive kind. And then the one on the right is a high-grade cancer that's aggressive appearing, and we treat it more aggressively because of that. But of course, like people, we cannot always tell how something's going to behave just by what it looks like. So, how can we get better at this? And this is where the genetics of the tumor come in and the genetics of the person come in. This is where we can get smarter by things that you can't just look at under a microscope. And this is, of course, where personalized medicine comes in. And we've taken personalized medicine, and nowadays personalized medicine is the right drug at the right time, in the right dose, to the right person. It's a pretty complicated paradigm, but it sounds pretty simple, and it's one we should be able to achieve. Now, I want to separate two things out. Howard spent a lot of time talking about the genetics of the person and touching on the genetics of the cancer. Those two things are really very different to our patients. The genetics of the tumor are always abnormal. That's what cancer is. It's abnormal genetics. Has to be abnormal, otherwise you wouldn't have cancer. It can't give us targets for drugs because the ways in which it's abnormal makes it different from the rest of your body. The genetics of the person can affect your risk. It can affect the effectiveness of your drugs, but it's your whole body. It's everything. You've seen this slide, which of course just highlights the reason that we do this, because there's a lot of heterogeneity in how people respond to what we do. Sometimes it's not working, sometimes it's too toxic, and so it doesn't matter if it would have worked or not if it makes the patient sick. So I'm going to give a shout out to Dr. Irvin, who's going to speak after me about evaluating the role of genotype, meaning your genes, in tamoxifen therapy. Tamoxifen, the most common drug that we use for breast cancer across the world, and it asks a very simple question. Can you compensate for inherited differences in how you manage tamoxifen simply through the dose? And Dr. Irvin is particularly well suited to talk about this because not only is he trained with us and is about to become a faculty member with us, but just this week he won an award for this work, the ASCO Merit Award for 2009. So you get an awardee coming up after me. So cancer, as I mentioned, this is the sine qua non of cancer is abnormalities in your genes. That's what cancer is. Now, lots of people have thought about the genetics of cancer, and people like to opine about what's important and what's not. And Francis Collins, who many of you know, very, very famous scientist, the head of the Human Genome Project, And he gets very enthusiastic about this stuff, and he once was quoted saying, "The sequencing of the human genome, along with other recent and expected achievements in genomics, provides an unparalleled opportunity to advance our understanding of the role of genetic factors in human health and disease." And he is 100% right. He's a little over the top sometimes, but this was spot on. But I have to say, my favorite quote about why we do what we do came from Sir Richard Peto, who is the father of cancer epidemiology. He's a Brit, and he tends to be a little on the crusty side. And someone was saying, gosh, you're talking about all these things that, each one seems to only make a little bit of a difference. And he said, yes, but even a small increase in the risk of being dead might be worth knowing about. So when we talk about tumor genetics, again, not people genetics, but tumor genetics, there's a few things that we have to acknowledge that's been a big change. So Howard showed you how much we've improved our ability to identify human genetics, people, what you're born with, and how it affects the drugs that we give. In truth, the genetics of the cancer is something that's also exploded over the last few years. So one thing, this kind of analysis didn't exist 10 years ago. But what we know now from genomic, meaning being able to look at all the genes at the same time and seeing patterns of behavior, has shown us that we can look at molecular portraits across a variety of cancers and identify characteristic differences that might that might inform how cancers are going to behave. So we know from this that breast cancer is not one disease. It's a family of biologically distinct diseases. So what does that mean? Well, it means, obviously, therapeutically, for me, the drugs that I use have got to be affected by this. If they're biologically different, then they're not going to respond the same to the same drugs. It also means that when we say what causes breast cancer, we're not asking the right question anymore, right? I mean, if they're different diseases, we have to ask what's causing each kind. And that's a big challenge for our future, but also a great opportunity. But it also means that individualized medicine isn't just a desirable thing. It doesn't just sound good, and it's something. It means that in order to get past that 40%, we have to do this, right? We're not going to get any better unless we recognize this and we target it. So gene expression patterns, all those little pictures that Howard was showing you, and the little genome, the little chips and all the little dots and things. All that is a way, now that the technology is so advanced, there are ways of looking at thousands of genes' behavior simultaneously, instead of one at a time, which, of course, when I was in my training, everybody had their favorite marker, and they would study it and study it and study it, and somebody down the hall would be studying something totally different. They had no idea what the guy down the hall, what he was finding, how it related to this guy's findings. But in truth, these kind of big portraits, which look at thousands of genes simultaneously, are something that can give us a huge amount of information. Of course, when you have a huge amount of information, you also have a challenge, and that's that analyzing it is incredibly complicated. And thank God for computers, because what a computer does is it takes these little bits of information that are really uninterpretable to the untrained eye, and it turns it into the picture. It finds out what's related to what, and it puts them together. So if you do that in breast cancer, you see a variety of subclasses of breast cancer. There are hormone receptor-driven breast cancers that we call luminals, and there's at least two kinds of them. There's actually probably more than that, but two are the ones that are the most common. Hormone receptor-negative breast cancer is made up of at least two different kinds, the basal-like, which many of my patients know of as the triple-negative breast cancer subtype, a normal-like type that we don't really understand very well, and a type that's driven by the protein HER2. And this is important because not only is it biologically different, but these have prognostic implications. They behave differently. If you blow up one of those Kaplan-Meier curves, which is just a survival curve, if you don't relapse, you continue along the top. See that? Yep. So this is doing well. Nobody's relapsing. This is one kind. This blue one down here, to me and to my pathologist, these look the same. These are two different luminal breast cancers, but as you can see, the patients with this kind, more than half of them have relapsed. The kind with this kind are doing just fine. These are the ER negative or hormone receptor negative subtypes that we have a lot more of a challenge with. So in addition to giving us information about biology, sometimes we can do something about the biology that we pick up. So for example, sometimes you find a protein or a gene in these profiles that's something that we have a drug for. So this EGFR or HER1, we actually have drugs that inhibit that. It is characteristic of one of the subtypes. It's probably largely irrelevant in all the others. So the studies that looked at this drug, when they treated all the breast cancers, they didn't see much going on. In truth, that's because it's probably only interesting and only relevant in a small proportion of tumors, and we have to figure out which ones they are. So there was a study, and here's the other challenge, and I show you this slide because now that we're separating breast cancers and other cancers into all these different subtypes, you can't do studies by yourself anymore. You can't go off and say, I'm going to test 100 breast cancers, because to get 100 of one kind of breast cancer could take you years. So we all have to collaborate much more than was the tradition. So scientists have to work together and clinicians have to work together. So in truth, it took a small village of academic institutions to answer the question about whether this particular approach could work in this subtype of breast cancer. And what we found, I'm just going to tell you very briefly what we found. This is one breast cancer, a woman who is the most, these very altruistic women who let us give these drugs and also let us biopsy their tumor, where we could look to see what the drug was doing and whether it was working and whether this is a fruitful way to approach treating this breast cancer. So you have one breast cancer. This is a pre-treatment, just a picture of her tumor. What I can tell you here is that this is a tumor where the drug goes after this. If it's red, it's on. If it's green, it's off. It's sort of the opposite of what you think it should be from a stoplight. So this is on, and here down here, this is red. This is basically the targets of this drug. And it's more red than green, so it's on. And 1 week later, it's turned off. The drug did what it was supposed to, and this patient responded very nicely. This is a triple-negative breast cancer, and the woman had been through multiple lines of chemotherapy, and none of them had worked. But even though that hadn't worked, this did work, and it worked for many, many months. So this is the ideal, right? If this was the case all the time, then we'd be, considering this a big home run. But here's the problem. With that particular trial, that happened 1 in 3 times. The other 2 and 3 times, it didn't happen. Sometimes, even though we expected the gene to be there, it wasn't. Sometimes the gene was there, but it didn't seem to be working, and we don't know why it wasn't working. Sometimes it looked like it was there, it looked like it was working, you gave the drug, and the drug did nothing. So the cancer had alternate ways of keeping going, because these are the drugs are supposed to turn off growth, and if it grows anyway, then something else is keeping it going. So unfortunately, we have to understand each cancer better before we can get to personalized medicine. So again, we're getting back to our one dumb tumor is still smarter than 10 smart oncologists, but I think we're catching up, and these are the ways that we're catching up, these kinds of studies. So let me just move to one last sort of element I want to talk about, and that's this idea of drugs getting smarter, right? Smart drugs and dumb drugs. So we always talked about, this is chemo, right? We call chemo dumb drugs, and then we have these targeted therapies that are our smart drugs. And the idea is that as your drugs get smarter and you know more about the biology of cancer and you develop drugs that go after an Achilles heel of the cancer that isn't there in the rest of your body, then you should have more specific effects and more effectiveness on the cancer and fewer effects on the normal tissue. And remember what I do. I give a lot of chemotherapy. Think about it, right? So hair falling out, that's the drug being not very smart and affecting a normal tissue, right? That's your hair falling out. That's being nauseated. That's all the stuff that chemotherapy traditionally can do. We're better at controlling these things, but it's still, these are the things we want to minimize. But we want to minimize it with maximizing the effects on the tumor. So you want to kill the tumor, but nothing else. So what about, in addition to trying to get the drug smarter, what about making the doctor smarter? So I want to highlight something that we're moving towards, which is genetic tests, not only to tell us when we need to treat more, but also tests that help us realize when a patient's tumor is not that aggressive and when we can treat less and not give chemotherapy when it's not required, for example. Now, a couple of years ago, there was a study looking at a genomic test, similar to these genetic tests, trying to identify tumors that were going to behave more aggressively and less aggressively if all you were going to give was an anti-estrogen pill, getting back to that patient that I talked about in the very beginning. So this is an assay to predict recurrence on tamoxifen in node-negative breast cancer. These are the genes. It's not that important. Just know that there's a bunch of genes that they developed to identify this very specific clinical question. And what they found was with these genes that they spent a lot of time developing, if they had a bunch of patients who had low-risk genes and they just gave them the pill, then they were going to do fine. Less than 10% of them were going to relapse, and even though they followed them out 12 years. In the ones with the high-risk genes, almost a third of them relapsed if all they gave them were the pills, and if they gave chemo, so a separate question they asked was, well, can we do anything about it? If they gave chemo, these were the patients that benefited from the chemo. So you're being much more thoughtful about who you're giving drugs to and who you're not giving toxic drugs to. So how are we going to do this even better? So we have to look at the risk factors now, right? What's our next challenge? Well, we'd rather the people didn't get cancer in the first place. And if they, in order to figure out whether some of the things that we've looked at, diet, exercise, you know, what kind of exposures you have, do they have any role to play in cancer? We have to be smart about which cancer we're talking about. So this is actually, School of Public Health doctors are looking at this right now. We have to get better about screening, right? Mammography is great, but there's a limit to how much it's going to help, and it doesn't help in certain subtypes of breast cancer. It's more helpful than in others. Improve treatments, getting the targeted therapies better, and identifying the patients that need more, not less therapy, but also figuring out how not to over-treat the women who don't need it. And that's, I think, as valuable an endpoint as anything. We're very good at adding drugs. We're challenged in taking away drugs. It makes us nervous. So one of the things that I think part of this I wanted to highlight is that, you know, I come from Hopkins, so, you know, this is Sir William Osler, famous internist, you know, the father of modern internal medicine. In truth, he did a lot of great things, but I have to tell you that I do research for at least half of my time, and I don't think I could do it the way he did it, because for us to do research nowadays and for us to actually get better at this, you know, we're a village. We're not one person. And we have, this is the Lineberger Breast Cancer Protocol Office staff that work on the research that we do. We have more, you know, researchers who do work in the scientific elements, not just the clinical trials, but trying to piece that together with the tumor-based studies. And even more importantly, remember, some of that really important data that I showed you before came because women let us do biopsies on them as they were going through the trials. They were partnered with us in this research, and they're as important to this as anybody else. Thank you very much.